Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Before starting this session, let me introduce the speaker for this webinar. He is none other than Professor Dr. Nishant Kumar sir, and let me share some of the achievement of sir. Sir has done MBBS, DA, DNB, MNAMS, professor at the Department of Anesthesiology, Lady Harding Medical College, and Associated Hospital. And today he is going to speak on a very important topic, that is a breathe away, a real world challenges in managing pediatric foreign body aspirations. So, any further delay, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
A very good evening. Today we'll be talking about anesthetic management of pediatric foreign body aspiration. Now, I have no disclosures, no financial disclosures. A few of the images might be from Google, but most of them are my own. So, we'll be covering the introduction. I'll be presenting a case, how we manage it, what are the associated complications, the anesthetic considerations, and certain gray areas or controversies on how these cases should be managed. Now, foreign body aspiration, as we all know, is potentially life-threatening. Now, in children, initially it should be managed as an initial attack, like with the Heimlich maneuver or pat taps, as per the ACLS guidelines. It is more common in boys in the age group of 1 to 3 years of age. Naturally, boys are more mischievous, they're more naughty, they like to put things in their mouth, and so foreign body aspiration is more common in boys. In spite of treatment, early diagnosis and treatment, morbidity and mortality remains high, up to 10% of the cases. And mainly it's because of a delayed or wrong diagnosis. Some might think that it has been because usually foreign body aspiration goes unnoticed unless until it is noticed and the parents know that the child has swallowed something and it has gone into the trachea and the respiratory tree. And when they bring the patient to the doctor, sometimes it is quite late and it is being treated on the lines of pneumonia or an LRTI or pleural effusion or something like that. Most of the times, even when the foreign body is detected, the clinical management sometimes, unfortunately, is not up to the mark, and therefore the morbidity and mortality remain high. Now, when we manage these cases in the OT, and there is no set technique per se. The experts have not arrived at a consensus that what is the best way to manage these cases. Either we should go in for an inhalational anesthesia or we should go with the total intravenous anesthesia. Whether the child should be breathing spontaneously or we should administer neuromuscular blocking agents, and some of these things we'll discuss today. So let's come to the case. So this was a 4-year-old male weighing 16 kgs and had a history of foreign body aspiration 3 days back. The child gave the history that he had swallowed something. There was a relentless cough without expectoration and excessive crying because of the difficulty in the relentless coughing and slight pain in the chest while deep breathing. The vitals were stable, the saturation, the child was eating normally, the BP was fine, the lab investigations are absolutely fine. On auscultation, there was definitely a reduced air entry on the right side of the lung. That was the only finding which was there. There was no fever, no chills, nothing. The child just had dry cough and excessive crying occasionally. Now, the child had come in the emergency in the evening, was kept adequately NPO for the OT the next day, and we took up the child with high risk informed consent, the need for an post-operative ventilator, a bed in the PICU, that is the pediatric ICU. Everything was explained to the parents, and they consented for surgery and anesthesia. Now, when we took up the patient, now this was the X-ray. Now, if you can see here, this is the nice bolt, steel bolt that the patient had aspirated. Now, this is a trachea, the left side bronchus, the right side bronchus. You can see the screw here in the right main bronchus. Even in the lateral view, you can see this is the oropharynx, the esophagus, and the screw is anteriorly in the airway. So the X-ray clinched the diagnosis that it was indeed in the airway, not in the esophagus, somewhere in the esophagus. So we took up the patient in the OT. Pre-medication was glycopyrrolate. because we were going to introduce a rigid bronchoscopy was planned, and so glycopyrrolate. Fentanyl, I usually prefer to give 2 to 3 mics per kg because this is painful. There's a hemodynamic response, and this is done on the table itself. Now, fortunately, this patient had a cannula in situ. He had a cannula secured on the left side of his hand, on the dorsum of the hand. In case the cannula is not secured, I prefer to induce with sevoflurane, induce anesthesia with oxygen and sevoflurane, and then take up an IV cannula, and then give glycopyrrolate fentanyl and dexamethasone as administered, just to reduce the inflammation and because of the airway manipulation that the surgeon is going to do. Anesthesia was induced with propofol and sevoflurane in 100% oxygen. The child the lungs are ventilated with a face mask using a GR circuit, and a MAC of 1.2% was maintained. Age adjusted MAC of 1.2% was maintained with oxygen and sevoflurane. That's all. Once the child was adequately under anesthesia and the jaw tone had relaxed, the jaw had relaxed, we introduced the ventilating bronchoscope. I'll just show a picture in the next slide. Under direct laryngoscopy, doing a Macintosh laryngoscopy, we introduced the ventilating bronchoscope, and the circuit, the GR circuit, was connected to the ventilating bronchoscope. I'll show it in the next image. We ventilated manually using sevoflurane and 100% oxygen with boluses of propofol as and when required. No muscle relaxant was administered. So, and if at any time the saturation went below 92%, the surgeon was asked to remove the scope. The airway was suctioned, and the patient was again taken on bag and mask with reintroduction of the ventilating bronchoscope. Now, if you see here, this is the ventilating bronchoscope. If you can see here, this is the bronchoscope with side eyes and a beveled tip. This is where the light source goes. This is where we attach the GR circuit. Unfortunately, the bag is not seen, but this is the GR circuit attached here. We usually attach EtCO2 also here. This port is to be kept closed, otherwise there will be leakage of gases. And this is the window from which there's an attachment, and this can be closed, and the lungs can be ventilated. And if the surgeon wants to do a procedure, then the slider is slid, this opening is open, and they can introduce the forceps or any other instrument through this bronchoscope. So this is introduced under direct laryngoscopy into the larynx. The trachea is identified by the tracheal rings and the bifurcation, the carina and the bifurcation of the bronchi, and then it is sided towards the foreign body, and the foreign body is visualized through this, and they can put an optical slit through this and attach a camera and monitor and see the proceedings on the screen as well. So that depends on the surgeons and the equipment that you have. So once this was introduced, we ventilated with a bronchoscope with 100% oxygen. Now, one of the major problems is that whenever the surgeon opens this port to introduce this thing or view, then all the gases are coming onto your face and the surgeon's face, and there's a lot of OT pollution because you have to keep a very high flow, and obviously you have to keep, since you're not using nitrous oxide, and ideally nitrous oxide should not be used. We should use either air if you want to reduce the oxygen percentage, but it is always better to ventilate with 100% oxygen in such cases. So naturally the sevoflurane concentration is, dial setting is also very high in these cases. Now, the surgeon, since it was a 3-day-old and a bolt in the right main bronchus, the surgeon took multiple attempts. There was hemorrhage in the right main bronchus, and we had to do repeated suction. At one point of time, the surgeon just could not visualize the bolt. So we thought, okay, it might have gone in, and you have seen the diameter of the rigid bronchoscope. It cannot go beyond the tertiary bronchi. So we thought, okay, fine. We put in an endotracheal tube, and we passed a flexible bronchoscope to ascertain the position of the foreign body. And once we saw the foreign body through the fiber optic bronchoscope, we withdrew the tube, again ventilated with bag and mask, and again introduced a larger rigid bronchoscope, ventilating bronchoscope, and repeated the whole procedure. Then, while taking out the surgeon withdrew the scope, and unfortunately, there was no foreign body that came out of the forceps. So, a check bronchoscopy was done again, but unfortunately, we could not see the foreign body in the airway. So the surgeon said, okay, we might have pushed it further. It might have gone and slipped into the esophagus. They decided to abandon the procedure. They said that we'll do an X-ray, and uh, they abandoned the procedure. So we decided to reverse the anesthesia. So the procedure was abandoned. We took the child on bag and mask. Once they removed it and we were ventilating with 100% oxygen, naturally the CO was switched off at this time. There was a sudden desaturation. The saturation dropped from 100% to 60%, 90%, then 80%. The ATCO2 also dropped, and the patient had a sudden bradycardia. The heart rate dropped from 100 to around 60. Now, this was a cause of alarm. Initial thought was laryngospasm because the bag was also tight. It could have been a bronchospasm because there was a lot of bleeding inside. And the last diagnosis was the most fearsome, a tension pneumothorax. There was a poor compliance of the bag. Immediately, we removed the drapes, saw the chest. The right chest was not rising. There was some subcutaneous emphysema around the neck and the face. We immediately tried and palpated the pulse. The saturation had dropped. We could not ventilate, and the heart rate was declining. The heart rate had declined to 40%. Immediately, adrenaline was administered, and the pulses were not palpable, so chest compressions were started. Within 2 minutes of chest compressions and injection adrenaline, administered IV, we simultaneously performed needle thoracostomy. If you see this apparatus, we just took an IV line. This was prepared beforehand, and it is always advisable to prepare this apparatus beforehand and be ready with it in a case of foreign body bronchus. It is just a 20 gauge cannula with a 5cc syringe. Now, this was prepared. This picture was taken later for the purpose of this thing, but you should fill it up to 2.5 mLs only, because then you have to aspirate the air. So this was just inserted in the right second intercostal space in the midclavicular line. Air was aspirated, and then a 3-way was attached, and IV tubing was attached and put into a saline bottle with saline in it. And immediately, the moment we did the needle thoracostomy, the pulse returned. The pulse was palpable, the heart rate increased, we could palpate the pulse. Thankfully, there was return of spontaneous circulation. So it was a tension pneumothorax which had caused the patient to crash. It was not laryngospasm, it was not a bronchospasm. We called the pediatric surgeons and they inserted an ICD, and there was a constant bubbling with a positive pressure ventilation. There was a large bronchopleural fistula which had been created because of the surgical intervention. The child was shifted, intubated to PICU, and maintained on spontaneous breaths on pressure support with sedation so as to decrease the bronchopleural fistula leak. The child remained in the ICU for around 2 days. On the second day, the trachea was extubated. He was observed for another 2 days in the ward with the ICD in situ. And finally, on the 5th day, the ICD was removed and the patient was discharged home without any deficit whatsoever. So the patient had an increased stay of another 4 days after the event. And during this time, what about the foreign body? When we performed a chest X-ray in the evening after the procedure, unfortunately, there was no foreign body to be seen inside the chest. So a diagnosis was made. Maybe this was not a foreign body of the airway. Next day morning, the patient passed the bolt in the stools. So basically, what had happened was that, as I said, while they were removing the foreign body, it had probably slipped into the esophagus and the oropharynx and the esophagus, and that is how it ended up in the stool the next day morning. So you have to be very careful. The foreign body could have been lost. The most dreaded complication would have been had it been lodged at the level of the carina. Then we would not have been able to ventilate at all. That is a real problem. So you have to be very careful when you're doing this, and you have to have it's like you have to observe each and every parameter. It's not just the monitor, but what the surgeon is doing, how the patient is doing, and you have to monitor each and every step and each and every part, especially the neck, the face, and the chest of the patient while you're ventilating in such cases. So, what are the anticipated complications in these cases? Number one is the loss of airway. Now, this is a shared airway. These patients desaturate very fast. Thankfully, this patient was not in distress. He was not having any wheeze or any chest conditions per se. But usually, these patients come in stridor, and it is difficult to have airway excess. Now, in these patients, if you give positive pressure ventilation, there's a further danger of pushing the foreign body further down. Again, as I said, even if it's in the trachea, it can cause and lodge it. It can go deep and lodge in the carina, and you won't be able to ventilate. It might go deeper into one of the bronchi, the secondary and the tertiary bronchi, and then again it will be difficult to retrieve it. There may be bronchospasm because of the airway reactivity, laryngospasm, again, reactivity in this thing. While retrieving the body, there can be massive hemorrhage, tracheobronchial tree injury, as it happened in this case, and you have to be very careful about this. Tracheobronchial tree injury is a potential life-threatening condition, and if you don't act fast, like this patient literally had a cardiac arrest on table, but with quick thinking, with quick diagnosis and recognition, we could uh, save this patient. Then pneumomediastinum, another complication. Loss of foreign body, again, which happened in this case. It can lodge into it can be displaced into the oral cavity, into the oropharynx, in the esophagus, and deeper migration, as I said, with the positive pressure ventilation, you can push in the foreign body much deeper inside the tracheobronchial tree. So, what are the anesthetic considerations? Now, the anesthetic considerations in these cases are ideally, if the child is stable, you should perform it during the day when all the expertise, the senior people are available. The most senior and the most experienced anesthesiologist should be present in the OT for this. Now, there are certain case reports and certain pediatricians try to remove the foreign body using flexible scope. Now, that is one way of doing things, but then the recommended method of removing the foreign body from the tracheobronchial tree is a rigid bronchoscopy under anesthesia. Remember, this is a shared airway. Now, one technique is to do it under apnea. You don't have a ventilating bronchoscope. Now, again, the guidelines say that you should be using a Storz ventilating bronchoscope, rigid bronchoscope, not any other bronchoscope for these kinds of procedures. Hypoxia, cyanosis, be very wary of them. It is always better if you administer preoperative steroids just to reduce the inflammation. And with positive pressure ventilation, I said the partial obstruction can turn into a complete obstruction. So even if you have to do a positive pressure ventilation, it has to be very gentle. Manual jet ventilation has been tried, but mainly in adults, not in children so much. You have to be on the lookout for complications. As I enumerated, the major thrust in these cases should be on the detection of complications. Complications are going to occur. You may not be able to prevent them, but if complications occur, you should be able to recognize and take action immediately. And obviously, at the end, once the procedure is done, you have to decide whether to extubate on the table or to ventilate postoperatively. That will depend on the airway edema, how much time it has been taken, what was the preoperative chest conditions, and arterial blood gas in this condition would help. Clinical signs, auscultation, how much hemorrhage is there, whether the child is maintaining saturation on minimal oxygen. Again, I would suggest that nitrous oxide not be used, because had we used nitrous oxide in this case, you can imagine the tension pneumothorax that would have increased. We were using 100% oxygen. So even if you want to reduce the oxygen concentration, it is always better to use air along with the oxygen and not nitrous oxide in these cases. Please do not use nitrous oxide in such cases. Either ventilate with 100% oxygen or use air and oxygen mixture. So while once the foreign body had been removed and the ICD had been inserted, we shifted the patient onto air and oxygen to reduce the FiO2. So, decision again to extubate or ventilate postoperatively will be a clinical one depending on the arterial blood gas and other parameters, and that can be taken. But then it is always better to explain this possibility of postoperative ventilation to the parents and to the surgeons and keep an ICU bed ready for such children. Now, what are the controversies or what are the gray areas, or rather, what are the contentious points in this? So, as I said, one way is that you do a bag and mask, you ask the surgeon to put in the bronchoscope, ask them to remove it as quickly as possible. Keep an eye on the saturation. Once the saturation falls, you ask them to remove and again go on to bag and mask. Now, this is, um, I would say, an intake way of doing things, not even old. This is intake. So, as I said, the recommendation is now to use the ventilating bronchoscope so that you can perform a gentle ventilation, or if not, keep the child on spontaneous respiration under anesthesia and assist as and when required with minimal pressures. If not, at least you're insufflating the trachea. Now, the other thing is whether to provide inhalational anesthesia or TIVA. Now, the beauty of inhalational anesthesia is that it's a quick in and quick out, specifically with sevoflurane. Um, but there is some amount of airway activity, and although the bronchodilation effect is there, the chances of movement is much more. Now, TIVA has really come up in this regard. So, a remifentanil propofol combination has been proved to be a bit superior to sevoflurane, although the older anesthesiologists would prefer inhalational based anesthesia. But then remifentanil propofol or even fentanyl propofol is a good choice in these patients, because propofol causes less, reduces the airway reactivity, relaxes the smooth muscles, and fentanyl provides adequate analgesia. So there's not much of a hemodynamic response itself. So remifentanil propofol totally acceptable, inhalational totally acceptable. I mean, it's what you can do best for the child, what you're more comfortable with. But remifentanil propofol has proved to be slightly better than sevoflurane. Spontaneous or controlled ventilation. Now, again, there's a big debate. There are certain surgeons who want the patient not to move at all. They want the cords to be nicely, widely abducted. They don't want the patient to be barking or having movement of the chest. Now, this is where I differ. Although you can have an immobile child with the cords absolutely relaxed with spontaneous respiration without the use of neuromuscular blockade. So you can have some respiration. You know when the child is having a tug or difficulty in breathing, and you can judge the compliance of the chest using the bag. And I would always prefer to ventilate with hand in these cases rather than put on the ventilator, because you can judge the compliance and whatever the surgeon is doing with the breath to breath accuracy with the control in your hand rather than on the ventilator. Now, this is one particular case where I would recommend that the bag is in your hand and you don't put the patient on ventilator. So, I prefer a spontaneous. I don't use muscle relaxants. I use propofol liberally, supplemented with sevoflurane, and I use adequate analgesia. Please do not compromise on analgesia. If you're using a muscle relaxant, now again the next debate is whether you're going for scoline or rocuronium. Now, scoline we all know is shorter acting, but then if the procedure goes on longer, you might have to administer non-depolarizing muscle relaxant. Now, with the advent of Sugamadex, probably we can administer rocuronium also. Suppose the case is finished in 5 minutes. It was an easy peasy, and the surgeon is quick and takes out the foreign body quickly. You can reverse with Sugamadex. And if the surgery is prolonged, you have the benefit of rocuronium, that you don't have to administer the relaxant again and again. So I've got it done under intermittent scoline also, but then intermittent scoline is no longer recommended because of the risk of bradycardia and phase 2 block. So NDMRs, scoline, no relaxant at all, the house is open to discussion. There are certain advantages of spontaneous, because with the spontaneous respiration, you're just assisting. So the migration of the front body is unlikely, and it gives you a better control. And if there's any loss of airway or anything, at least the child would be breathing spontaneously, and we won't lose the airway. There would be some ventilation happening. Then once the procedure is done, once the rigid bronchoscope is out, so do we bag mask or do we intubate? Now, again, if you have administered NDMR and you feel that it will take a longer time for the child for the respiration to return, it's always better to intubate. But then again, during intubation, you can cause injury. There has already been trauma to the airways. Putting in a tube might further aggravate it, but then you have to be gentle. And sometimes putting in a tube will also let you know about minor rents or something which have been there and they might be aggravated. So the choice is entirely yours. I prefer to do a bag and mask unless until there's been a complication like this one. And if the child is on spontaneous, I know with the bag and mask, I would be able to I have to just switch off the sevoflurane, wait for the action of propofol and sevoflurane to wane off, and I can just observe the efforts, and I'm not worried about post-operative residual paralysis at all. Now I know why the child is not breathing, whether it's the chest condition or the hemorrhage which is there, or the wheeze which is there, and not because of the muscle relaxant that the tidal volume is low or that the patient is tachypneic. So I'm not worried about incomplete reversal in these cases. So I prefer a spontaneous technique. But remember, with the spontaneous technique, the chances of bronchospasm and laryngospasm have been reported to be higher vis-a-vis the controlled ventilation, and you might have to manage laryngospasm in such cases. So there are a wide variety of options for anesthesia in such cases, but then you have to have your clinical experience, your judgment, and one thing, you should know what all complications can occur and how you're going to manage them. With that, I'll end my talk here. Thank you, and I'm open to questions. Over to you, Faraz.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too, sir. We have received some questions, sir. With all your permission,
Yeah,
shall we
sure.
take these questions?
Please.
First question I can see, sir, like from Dr. Subramaniam. He is asking, what is your approach when imaging is inclusive but clinical suspicion remains high? What's your point of view on that, sir?
In this case, see, imaging is inclusive, but clinical suspicion is high. So rather than with an X-ray, it will be better to go in for a CT. Then that will conclusively prove whether this is a foreign body or not in the airway or not. If it's not in the airway or wherever the foreign body is, it has to be removed. Suppose it is in the esophagus, again it has to be removed. But then the surgeon have to be absolutely sure. Then I'm sure I can intubate. I can intubate the trachea. I can have a controlled ventilation, and the surgeon can take their own sweet time taking out the foreign body from the esophagus. So it all depends. But I would like to have a conclusive radiological evidence rather than unless until the child is heavy, is hypoxic, is cyanotic. I know the X-ray is not telling me, but the clinical sign and the clinical condition of the child does not permit any further radiological um, imaging. So in that case, yes, I would take up the patient. I would rely more on clinical signs. But if the child is stable, if the patient is stable, I would preferably go in for a CT scan rather than relying on clinical diagnosis alone.
Thank you so much, sir, for sharing your insight on this question. I hope that Dr. Subramaniam has received his answer. Moving forward, we have another question from Dr. Singhania. Abhishek Singhania, he's asking, do you routinely use fluoroscopy or virtual bronchoscopy in different cases, sir? Can you please highlight some point on that?
No, no. We just usually get an X-ray chest done, AP and lateral, or if there's a clinical evidence of this thing, even then an X-ray chest is done, and we go in for a rigid bronchoscopy.
Thank you so much, sir, for answering this question. We will go move to another question, sir, from Dr. Sarkar, and he is asking, what are the common complications you have encountered post removal, and how do you mitigate them, sir? Can you please share some
So,
of your real time experience?
yeah, so we have had bronchospasm, we have got laryngospasm. We have got some subcutaneous emphysema as was encountered in this case, lost foreign body. In fact, this is why I presented this case, because I have enumerated all the complications that could have occurred. There has been hemorrhages also. So these are the common complications. The chest, which was absolutely fine earlier, now because of the trauma caused by the instrumentation, um, the chest has become bad, and we had to ventilate the patient overnight. So all these complications, that's why I picked up this case. This case highlights all the possible complications which could have occurred.
Thank you so much, sir, for answering the question, sir. As I can see, one feedback, Dr. Subramanian is writing that thanks for responding my question and amazing case presentation.
Thank you so much, Dr. Subrahmanyam.
Welcome, sir. As I can see, sir, there is no more for the further questions. I hope you have done justice to this topic, sir, and you have brilliantly explained the real-time case study. I hope it will help all the PG students also who have joined this session on their real-time experience and practical approach too, sir. Sir, as there is no more question, with all your permission, shall we conclude this session for today?
Yeah, please. Thank you.
Thank you so
Thank you.
much, and we would like to see you soon, sir, with different topic. Till then, take care of yourself, sir.
I
Have a
would
great.
ask the audience to suggest any topics that they would like to let me
Yes,
talk
yes.
on.
If there is any suggestive topic from your end, you can put it in the comment box. We will go through it and we will cover in future. With
Thank you.
this, we are closing for today, sir. Thank you so much once again.
Thank you.